Everyone, and welcome. Today, we're going to tackle a very important topic, one that is guaranteed to show up on your exams, the stomach, and of course its most notorious inhabitant, Helicobacter pylori.
So here's the central question we're going to answer today. How can one single tiny bacterium be responsible for so much trouble, from common stomach ulcers all the way to stomach cancer? We're going to connect all the dots right from basic physiology to the clinical management you'll use in your practice.
So, here's our plan. We'll start with the basics of stomach anatomy, then we'll get into what gastritis actually is. After that, we'll meet the main culprit, H. pylori, and finally, we'll cover how to diagnose and manage it. A logical path, from basics to bedside. Let's begin.
All right, first things first. Before we can understand any disease, we have to master the normal. So let's start with the normal anatomy and physiology of the stomach.
Okay, pay close attention to this table. It's absolutely crucial to know which cells are where. For example, look here. The parietal cells are in the body, and what do they produce? Acid and intrinsic factor. And the G cells? They are in the antrum, producing gastrin. This concept, that location equals function, is the key to understanding everything that follows.
Now, just think about it for a second. The stomach is basically a bag of hydrochloric acid, right? So how does it stop itself from getting digested? Well, it has these incredibly powerful protective factors, things like prostaglandins, which help create a thick, protective mucosal barrier. It's a fantastic defense system.
Now, this is a beautiful concept. Acid production isn't controlled by just one single switch. Instead, you have three key players: gastrin, acetylcholine, and histamine, all working together, all stimulating the same parietal cell. This is what we call cooperative synergism, and it's how the stomach can really crank up acid production when needed.
So, now that we know the normal, let's see what happens when that beautiful protective lining gets inflamed. That condition, my friends, is gastritis.
So what is gastritis really? Simply put, it is the histological inflammation of the stomach's inner layer, the mucosa. And for your exams, for your MCQs, you must always remember the two main culprits: the infectious agent H. pylori and damaging factors like common painkiller drugs, the NSAIDs.
Okay, everyone, this slide is extremely high yield, so listen carefully. In type A gastritis, the A is for autoimmune. The body attacks its own parietal cells. Now, where are the parietal cells? In the body, exactly. So what happens? You lose acid, which is achlorhydra, and you lose intrinsic factor, causing megaloblastic anemia. See the logic? In contrast, type B for bacterial, is caused by H. pylori, and it mostly affects the antrum.
Now, let's focus on our main culprit. How can this one single organism, H. pylori, cause so much trouble in such a harsh environment like the stomach?
Here's the key profile. Yes, it's a gram-negative bacillus, but the one property, the one fact you must never, ever forget is that H. pylori is urease positive. This single enzyme is the absolute key to its survival.
So how does it do it? How does it survive in a place with a pH of, say, 2? Well, this urease activity is a brilliant survival mechanism. The enzyme takes urea from the stomach and breaks it down into ammonia. And what is ammonia? It's alkaline. This neutralizes the stomach acid right around the bacterium, creating a safe, cozy little bubble for it to live in. It's genius, isn't it?
And it's not just about surviving. This bacterium comes fully armed. It has an entire toolkit of weapons. It uses flagella to swim through the thick mucus, adhesins to latch onto our cells, and it even has this sophisticated system to inject toxins and other proteins directly inside our cells. This is a remarkably well-equipped pathogen.
In this slide, this illustrates the most dangerous long-term risk of H. pylori. The chronic inflammation from the infection starts a terrible cascade. Over many years, it forces the stomach lining to change into something that looks more like the intestine. We call this intestinal metaplasia. This can then progress to dysplasia, which is basically precancer, and ultimately to gastric cancer. This is exactly why we must find and eradicate this infection.
So a patient comes to you with that classic burning epigastric pain. How do we confirm that our bacterial culprit is actually present? Let's talk about the investigation.
We have both invasive and non-invasive options. Now, the gold standard is an endoscopy with a biopsy. With that biopsy sample, we can do a rapid urease test. But we also have great non-invasive options, like the stool antigen test and the urea breath test. The breath test is really clever. It's based directly on the bacteria's urease activity to give us a clear positive or negative result.
Okay, now for the final, and I think the most practical part, the clinical application.
We found the enemy. How do we treat this infection? Now please listen, this is the most crucial point in management. Our goal is not just symptom relief. Our goal is eradication. We have to completely eliminate the bacteria from the stomach. This is the only way to truly cure the patient and prevent those long-term complications like cancer.
The standard first-line therapy is a triple drug combination, usually given for 14 days. It is very, very easy to remember. It's a PPI, like omeprazole, to reduce the acid, plus 2 antibiotics, clarithromycin and amoxicillin, to kill the bacteria. Simple as that.
This flowchart is your clinical guide. It's what you do in practice. Step 1, test. If it's positive, you treat with the first-line therapy. Then, and this is critical, you must wait at least a month after treatment ends, and then you retest to confirm the bug is gone. Never, ever just assume it's gone. If that treatment has failed, only then do you move to a second-line therapy. Always, always confirm eradication.
Okay, let's do a quick revision of the absolute high-yield points. 1. Parietal cells are in the body, they make acid an intrinsic factor. 2. Type B gastritis from H. pylori carries a very real risk of adenocarcinoma. 3. H. pylori's #1 survival tool is its urease enzyme. And 4. As a clinician, you must always confirm eradication after treatment.
And I'll leave you with this final thought. All over the world, we are seeing a rise in antibiotic resistance for H. pylori. Our standard triple therapy is failing more and more often. So the question for our generation of doctors is this: how will our treatment strategies have to evolve to combat this growing challenge? Think about it.